Good evening, everyone. Thank you for joining me today. Prevention is a team effort. Dental hygienists, assistants, office staff, and the dentist must all work together to be most effective. We have to establish office protocols, and we have to agree upon those so that patients at risk receive evidence-based treatment, not just what insurance covers. You're going to discover how many more patients are at risk of developing new decay and just how easy it is to address, especially in a dentist chair. We're also going to discuss establishing billing and payment approaches so that not only is appropriate treatment performed, but it's also collected. The payment is collected. Whatever your role in the office, the goal is the same. We're looking for happy, healthy patients, a fulfilled staff, and a profitable practice. I'm really happy you all joined us tonight. I love this platform with Viva Learning. We have people tonight from Romania, Australia, India, Ireland, Albania, Costa Rica, just a list of places that I want to go. And there are about 30 people from Qatar. So welcome, everyone. Welcome, welcome. I do have to go through a few disclaimers here. I would like to thank Centrix Dental for sponsoring me to be with you for this course. They are the makers of Fluoridose Fluoride Varnish, and it is the Dental Advisor Fluoride Winner of the Year 5 years in a row. I love this varnish, and I know that you and your patients will too. It is important that I point out that using fluoride varnish in adults for caries prevention and treatment and reversal is still considered an off-label use. It is, however, considered to be safe and efficacious, and it's recommended by the ADA, and it's taught in every dental school in the United States. Now, this course was written and delivered by me. These are statements by me, not by Centrix Dental or anyone employed by the company, and I am not an employee of Centrix Dental. So enough with the small print. For this course, I'm going to make the assumption that you're familiar with caries management by risk assessment and the prevention strategies that go along with it. If you want to refresh or learn more, please go to vivalearning.com and you can search my name. You're going to see 3 previous webinars on the subject. The first is an introduction on how to implement evidence-based risk management and prevention into your patient visits, including how to complete the risk assessment forms. The second webinar discusses overcoming the barriers to providing the preventive care, and the third utilizes case studies. I really like this one. It utilizes case studies for those with risk factors attributed to infants all the way through college age. Now, even if you haven't viewed these courses, you should still be able to follow along with tonight's course. Now, allow me to introduce you to my father. If you've been to the other webinars, you've seen him too. This is my dad, Billy. He was a simple Southern boy raised in Mississippi. My dad dropped out of school in the 8th grade to help take care of his sisters and his parents. You can see him and his sisters right there. He worked in the oil field with my grandfather, who passed along a really great gift to my dad. They were both really great storytellers. When I was a kid, Daddy would grab an apple from the kitchen. He would bring it to me wherever I was, and he would pull out his pocket knife, and you can see that is his pocket knife in the middle. He would peel an apple in one long ringlet piece, all one piece, and I was mesmerized every single time he was successful. And I always thought he was slow, but I came to realize as I grew up, as I was an adult, I realized he was just taking his time, and he was taking this time to impart advice while he had me held captive. He told me stories about when he was a kid. He told me about all the mistakes he made, all the fun he and his sisters had. And through his stories, he taught me how to act in public. He taught me how important it was to learn in school. He taught me how I should expect to be treated and not treated by friends and by boys, all while skinning an apple. I was his captive, and he used his time well. Your patients are captive in the chair. They're your captive audience, but it's only for a short time. Are you using the time in the chair wisely to impart your advice and to make their futures better? So just like your children, we only have patients in the chair for a very short time. We need to make use of it. So let's review so that we're all on the same page. And yes, that is me, little redhead in the right-hand corner. We just had National Redhead Day last week, so got to be involved in that. So let's look at some proven risk factors. I'll let you read through these on your own. In 2007 and again in 2013, the ADA scientific panel released documents describing evidence-based risk factors in the clinical recommendations for use with professionally applied topical fluoride and home fluoride, and this was for the prevention of caries. This was a 113-page document that they reviewed, and it was research after research after research after research. Most of the 113-page document was listing all of the research that they reviewed for this. They reviewed professionally applied fluorides as well as home prescription strength fluorides, and they made recommendations based on efficacy, risk, and safety. Now, to help dental professionals determine the risk, they provided a detailed list that you see here. The items that I highlighted in red, those indicate a high risk. The others are moderate risk. If, however, your patient has multiple moderate risks layered, they can be considered high risk, but the ones that are in red indicate high risk. Now, research is very clear that one of the biggest risk indicators for developing caries is having caries. We know that caries is a bacterial infection, and once you have decay removed, the infection isn't gone. That bacterial imbalance or overgrowth is still present. We must use intervention strategies to help the patient reduce their risk. And these strategies include strengthening the enamel, neutralizing pH, and reducing the bacterial load. We are very familiar with the need for children to receive preventive fluoride treatments, but their risks don't suddenly go away when their insurance does. On the contrary, adults have all the same risk factors that kids do, but then they start to pile on even more risks over the years. They don't suddenly become great at biofilm removal. They don't suddenly stop drinking their acidic or sugary drinks. They do, however, add xerostomia-causing medications, and they do develop areas of recession. Xerostomia is a very common risk factor with your patients. One study released by the Mayo Clinic a few years ago revealed that 70% of Americans take at least one prescription medication and 20% are on 5 or more. And as you know, a patient can have loss of saliva without even being aware of the problem. Root exposure is another important one on this list. And it's a prevalent risk that is often overlooked simply because we see it all the time. It's so often. Research tells us that 50% of people over 18 and 88% of people over 65 have recession. So more than 50% of your patients have recession, and these sites are at a greater risk of decay than the adjacent enamel. Inadequate biofilm removal, drinks between meals, prescription medication, and recession. I likely just described over 60–70% of your patient base. So are you providing fluoride therapy and other preventive methods for over half of your patients who enter your office? If not, you're really missing an opportunity to improve their oral health, and that means your practice health. Don't worry if you didn't get to write all of these down. You can find these on the blog section of my website, and you will get that later. This is the clinical recommendation document from the ADA scientific panel. You can find a link at the end of the presentation, or I'm happy to email it to you if you have difficulty finding it. And again, my email is on my website that you'll see later. There are several things on this guide that I want to bring to your attention. Let's start at the top, the red circle. This chairside guide is for those patients found to have an elevated risk. That is, did they have any of the risk factors on the previous slide? If so, this is the guide. This is the guide that's going to tell you how to proceed. If the patient does not have any evidence risk factors, they are considered low risk, and research shows there is no benefit to providing supplemental treatment. Now next, I'm going to expand the 2 rows that are in front of the red arrows, and those are important for getting us on the same page with patients. So this is just a cutout of the previous document. These are the in-office fluoride recommendations for adults and adults at risk of root caries. Now please know that 5,000 parts per million toothpaste and fluoride rinses are also part of the recommended treatment for adults, but we do not have time to discuss those protocols tonight. You can review that ADA document, or you can go back to the previous webinars for full information. For adults at elevated risk for developing decay, the ADA recommends in-office fluoride treatment at least every 3 to 6 months. That can be a fluoride varnish, or it can be an acidulated phosphate fluoride gel, but that has to be worn in a tray for a full 4 minutes. There is no such thing as a minute gel, and remember that if the patient has any crowns, composites, sealants, any restorations like that, you can't use acidulated phosphate. Now, because of these restrictions and just the sheer ease of use of varnish, I'm only going to refer to fluoride varnish for the rest of the course, but be aware that acidulated phosphate fluoride gel in a tray for a full 4 minutes is also an option. Now, if the patient has a moderate risk for decay, you can see that they need at least twice a year. That's the recommendation for fluoride treatment from the ADA. If high risk, they recommend at least 4 times a year. Now, notice I said at least, and that's because the California Dental Association recommendations are to apply up to 3 treatments initially and then another at each recall throughout the year. Now, look at adult caries. The panel gives expert opinion for using fluoride varnish to prevent root caries in your adult patients. I can honestly see the day that fluoride varnish gets FDA approval for adult caries prevention and even reversal. In fact, you might not have seen it yet, but the Journal of American Dental Association in October, just last month, the ADA gave further guidelines for root caries prevention and even root caries reversal. So look up that document. And if you can't find it, again, just email me and I'll send it to you. After you determine your patient's risk category, you can use these recommendations. Now stay tuned. I'm going to introduce you to a few easy evidence-based worksheets that will help you do it very quickly. One for the hygiene chair and one for the restorative appointment. My personal choice of fluoride varnish is Fluoridose from Centrix. Now Fluoridose was awarded the top fluoride varnish in 2015, 16, 17, 18, and I just heard that they won again for 2019. It continues to win the top varnish because clinicians love that it is smooth, it doesn't get stringy, it doesn't get clumpy. I can apply the Fluoridose while I'm standing or sitting, and it takes, I'm not kidding, less than a minute. My patients love that it stays clear, it isn't fuzzy like the other varnishes I've used over the years. Fluoridose, it dries in seconds, it remains on the tooth for 6 to 8 hours while it does its magic. And it comes in great flavors, something for every age: bubblegum, mint, cherry, melon, and my personal favorite, caramel. It's also a great value. We spend about $1 per dose at our office. Now, by the way, I'm in Oklahoma City, Oklahoma. It's really cold here right now. But let's make sure that we are on the same page with fluoride varnish. I want to make sure that everyone agrees that with the American Dental Association that fluoride is an important part of caries prevention, and the ADA also says it's really important for part of your intervention plan. Now think to yourself, if your dad had exposed root surfaces and took medication that reduced salivary flow, would you treat him with a fluoride varnish the next time he came into the office? If your spouse was in orthodontic brackets and drank sodas or energy drinks, would you make them have a fluoride treatment even if they protested? I know I would. Everyone in the office has to believe in prevention for life. It is scientifically possible to go a lifetime, or at least the rest of your lifetime, without decay, because as we know, decay is a bacterial infection. We can break the cycle with effort, but it takes the entire team. We have to use the patient's time in the office to educate them about cavity prevention. We have a captive audience. We have to use that time. The ADA and the California Dental Association have very detailed risk assessment forms that I suggest you start with to get the full understanding of how risk factors layer and how they increase individual risk. I'm going to introduce you to 2 forms that are faster and easier for the entire team to use. The first one you see here is the patient self-assessment, And it helps the hygienist to quickly classify the patient. It gets the patient involved in co-diagnosis. And you know, anytime you can get the patient involved, it's going to help them commit better to treatment. The next one is for the dentist and the assistant to use in the restorative room. This isn't only to improve the patient's chance of preventing a recurrent decay, but it also increases the patient acceptance on recall visits. You don't have to go searching for these forms. You can go to my website, www.donnabroganrdh.com, and you can download all of these forms at no cost. You can also find them at cariesprevention.com. Suddenly become excellent at biofilm removal and eating acidic diet when they turn 18. On the contrary, they maintain these risky behaviors and they add in a few new ones. We dental professionals are to blame for patients not thinking that fluoride is important for adults. We've let insurance companies drive our treatment of patients for way too long. If you see 8 patients in your chair tomorrow, I would be willing to bet that at least 6 of them have something from that list of evidence-based risk factors. How many of them will you provide with a fluoride varnish or 5,000 per million fluoride toothpaste, or even a discussion about caries prevention? We need to talk as much about caries, at least as much as we do about brushing and flossing. Fully implementing prevention in your practice starts when the patient walks in the front door. You want them in a dental state of mind, so I want you to get rid of the gossip and fashion magazines. You should have educational information out on the tables or framed on the walls. And you might already have a display of before and after photos of your aesthetic work. You can also display a few images of decay at a crown margin or broken fillings and mark them clearly as having new cavity that undermined the restoration. Kind of like this one right here. You might have that picture in the waiting room, but I want you to clearly mark, hey, that's decay. You can also place a copy of the list of known risk factors on the tables also so that the patient can realize how many things are undermining their dental health. When the patient arrives and checks in for the dental hygiene appointment, hand them this self-assessment form. Here you can see the waiting room patient self-assessment form for caries risk. Have the front desk team hand the clipboard to the patient as they walk in. The patient is going to fill out this form to the best of their knowledge, and it's okay if the patient doesn't know that she has recession. The hygienist can absolutely add that during the exam. This is a marketing tool as much as it is an educational tool. Your patient is reading that recession, medication, snacks, and the afternoon coffee with sugar. She's reading that all of those are risks for her getting a cavity. This involves the patient in co-diagnosis. They know they're at risk before they even sit in your chair, so it cuts down on the perceived nagging that a lot of people think that hygienists do. Any additional findings can be added during the oral evaluation. So let's go ahead and go to the hygiene room. So Monica came in today. She completed the form to the best of her ability in the waiting room. And after doing the exam, we discussed how the combination of her root exposure and her medication put her at risk of developing caries. So you can see here on this page, she had an opportunity to mark what she knew, and then we can go back as hygienists and mark what we find during the exams. So we talked to Monica about the areas where she's missing biofilm and when she's brushing, how to improve. So this is a patient that I see several times a day in practice. She isn't the best at biofilm control, and she's on at least one medication that is known to cause xerostomia, even if she doesn't realize it. And she has recession on her molars. When you combine a loss of saliva with exposed root surfaces, you have a cavity waiting to happen. Root surfaces have half the mineral content of enamel, so they demineralize and decay much faster. When you reduce or lose buffering capability of saliva, decay occurs even faster. This isn't something that we only see in elderly patients either. According to research published in the Journal of American Dental Association, more than 50% of the population has more than one site with gingival recession of 1 millimeter or more. The percentage certainly increases with age, but recession is seen as early as the teen years and quite often in young adults. I know myself, I've had recession on my maxillary first molars since at least I was 21 in hygiene school. Using your professional judgment you decide that Monica is a moderate risk and you prescribe 2 fluoride treatments a year. If she had more yellow check marks, or if she had decay, or if she had a layering of risks, my professional judgment would be to bump her up to a high risk and do 3 or 4 varnish applications. But since she hasn't had any decay and is only on 1 prescription medication right now, I'm going to keep her at moderate risk. So my recommendation for Monica is I suggest 2 applications a year of fluoride varnish and that she uses the Sonicare toothbrush. She has a really easy treatment plan. I'm just going to place varnish at her 6-month recalls. Now David is what I would call an easy prophy patient. He brushes and flosses very effectively. He has very little calculus and no bleeding, but he drinks bottled water, which you and I both know doesn't have fluoride, and much of the bottled water on the market actually falls on the acidic side of the pH balance. And he drinks cola. And of course, he has numerous areas of recession. So when you add the bottled water, the cola, and the numerous areas of recession, and the fact that he has cervical decay today on an existing restoration, you can see everything that I added to his patient assessment. So I added a little bit that he didn't know about because he does have decay today. So he completed the self-assessment. We discussed his recession and his choice of beverages. And because he has active decay today, he is automatically at a high risk for developing more decay. My professional judgment and the guidelines from the ADA, they make me recommend fluoride varnish at least 4 times a year, a 5,000 parts per million fluoride toothpaste, and I'm going to ask him to choose xylitol gum 5 times a day. Now this is going to be his recommendation until he goes 24 months without additional decay. I place the fluoride after the dentist diagnoses the caries, and I hand him a tube of ClinPro 5000 or Prevident Booster. Those are the 2 that I really like in the office. Since he needs 4 applications of varnish a year, we're going to have to increase his visits to the office. So 2 of those applications are going to happen at his 6-month recall and 1 at the restorative appointment when the dentist removes the decay, but we're still going to need 1 more appointment. Now he can come in for a varnish-only appointment between his recall visits, and a hygienist or an assistant or whoever is legal in your area can place the varnish. It should only take a couple of minutes out of his day, and you may or may not need an operatory. We're going to discuss these extra visits and how to make them happen a little bit later in the program. When a patient is in the chair waiting for anesthesia to take effect, the assistant and the dentist have a captive audience again. Now use this time to reinforce what the hygienist prescribed at the recall appointment. You want to review the level of risk they have and the preventive measures that you're going to use to reduce that risk. I've spoken to many hygienists about patient acceptance of fluoride varnish at recall appointments, and something became very clear during these conversations. Without exception, when the dentist is involved in education, the patient had better buy-in to the treatment. When the doctor reinforces the hygienist's recommendations from the restorative room, the patient is much more likely to accept fluoride varnish at the next hygiene appointment. Take advantage of this captive audience. Help your hygienist succeed and help your patient succeed. Aaron is in the dentist chair today because a month ago, radiographs revealed that he had new decay on the mesial of 28. Now remember, the #1 risk for getting a cavity is having a cavity. The patient has to eliminate the bacterial imbalance in their mouth, and they have to get control of the pH, and they have to change their habits. While the dentist is out of the room, the assistant has a captive audience and can discuss this. So let Aaron know that this is an old filling that had a new decay area and that he does have the power to keep this from happening again. Use this form to review the suggestions from his hygiene appointment. It's going to be fluoride varnish 4 times a year, 5,000 parts per million toothpaste twice a day, and xylitol gum 5 times a day. Now the doctor comes back in the room to place the restoration, and then depending on the law where you live, either the doctor or the assistant is going to apply a coat of fluoride varnish. It takes 1 minute and it costs less than $2. This form is designed as a takeaway for the patient. It's just one more reminder of their risk factors. If they are receiving a restoration today, it's almost always a sign that there was new decay. The more involved the doctor is in prevention, the more acceptance the hygienist is going to receive from the patient at the next recall visit. For this reason, ask your dentist to always make a positive statement about the fluoride and its importance at the next recall visit. Aaron has already told the hygienist that he isn't sure he wants to pay for the extra fluoride varnish since his insurance plan doesn't include assistance. This would be a great time to provide a complimentary varnish and stress the importance of receiving 4 per year until his bacterial infection is resolved. An example dialogue from the doctor could be, Aaron, I removed the new decay in your tooth and placed a beautiful filling today, but that doesn't resolve your bacterial infection. I know that Julie explained at your last appointment that fluoride varnish is an important part of this filling succeeding and helping you to not get another cavity. Because this is so important, we're giving you a varnish today at no charge. I really want you to stop getting cavities. I have faith that you and Julie will get this under control. She's really good at helping people just like you. I can't stress enough how important it is to get support from the doctor and the assistant from the restorative room. You're going to notice the patient acceptance going up if the dentist and the assistant get involved in praising prevention techniques. So again, while the anesthesia is taking effect, the assistant has a captive audience. Use that time to discuss prevention and support and to promote what the hygienist advised at the last appointment. So the assistant, while the anesthesia is kicking in or while the doctor's checking a hygiene appointment, the assistant can say, Aaron, how are you doing with the toothpaste that Julie prescribed at your last appointment? Great. If you use it twice a day and chew the xylitol gum like she told you, you can reduce the amount of cavity-causing bacteria in your mouth. At the end of the appointment, we're going to place a fluoride varnish, and this is kind of an insurance policy to protect your new filling. It's going to be a team effort, but we're going to work really hard to make sure that this is your last cavity. These are some comments that I've collected from friends and colleagues across the United States who have implemented a prevention protocol in their office. They've seen numerous advantages to promoting prevention through professionally applied fluoride and using at-home prescription toothpaste and rinses. Now, I love that assistants are excited about providing care. Assistants overwhelmingly say that they enjoy the conversations they are having with patients about risk and about prevention. They feel like they're a bigger part of the team when they get to be part of this. It's an added advantage that when everybody in the office starts talking about prevention, the patients actually start expecting a varnish application at their next appointment. Assistants love doing this, and it really does make a difference in the acceptance with the patients. So David is in the doctor's operatory today for his appointment to have number 8 crown seated because the previous crown had recurrent decay. He is officially in the irreversible restorative cycle where his old restorations are starting to break down and decay. They're requiring bigger and more aggressive restorations, and he doesn't have to accept this. We can help him break free of this cycle. Here is another opportunity for the dental assistant and the dentist to reduce the risk of caries in a patient. You can't remove the decay and place a crown and expect the infection to go away. The patient's going to be at risk for 24 months until this decay is gone, until this bacterial infection is gone, and they're at an even greater risk because of all of the root surfaces exposed. Use the hygiene appointment notes to complete the restorative risk assessment and review the preventive suggestions. You can send this home with the patient, and you are probably thinking about making this form digital. Don't do it. You want the patient to take this to the car, see it a few times in the next few days, and maybe even save it. If you make it digital, it dies as soon as they stand up from the chair. So don't digitize this. You want this to be on a hard piece of paper and have it walk out the door with the patient. So here you can see the risk factors that were there when the hygienist saw the patient, and they're there again today when the doctor is seeing the patient. The recommendation is in-office fluoride 4 times a year, prescription toothpaste 2 times a day, xylitol gum 5 times a day. So And you definitely want to promote what the hygienist has recommended for the patient. Think of how much a crown costs in your office. In our office, the fee for a porcelain crown is about $12.50, more for anteriors. So imagine that you seated this crown on your patient 1 year ago, and at their recall appointment, you had to tell them that they had new root decay on that beautiful, expensive crown. An increasing number of progressive thinking dental offices are providing what they consider to be longevity insurance. They're applying fluoride varnish at the crown seat appointment at no charge. The dentist is making a big deal out of the fact that she's doing this at no charge and stresses how important it is to get those 4 varnish applications per year to protect the investment. It takes 1 minute and it costs less than $1. Words of support are powerful. If your dentist tells the patient how important the caries treatment plan is, they're more likely to comply with the prevention recommendations. So here's a dentist dialogue. David, thank you so much for being a great patient. You did have new decay around your old crown. I was able to remove the cavity and the final crown looks great. You still have a bacterial infection and it's going to take a combination of homework and extra visits to see us for fluoride varnish 4 times a year. I placed one of those today at no charge because it is so important for the longevity of your new crown. Julie is an expert at helping people just like you beat the infection. You should do everything she recommends. It's a team effort, but we're going to work really hard to make this your last cavity. Here are a few more comments from across the United States. One office commented that they are, even though they're providing free varnish application once a year to their at-risk patients, they're still selling more varnish than they ever did before. Patients notice, they really notice when you start giving individualized care, and they start talking more about preventing future problems. And when more people accept prevention therapy, guess what? When people accept more prevention, office production goes up, not down. A hygienist in Connecticut just the other day told me that their production has gone up 3-fold since they started the Prevention for Life program. And the patients feel like they are being treated special. So they don't feel like they're being sold to, they actually feel like they're being treated special, and they feel like they are individuals. So these are just suggestions from across the country, from assistants, hygienists, from front desk people. When you start doing a preventive program, your production is going to go up and your patients are going to be healthier. As I mentioned, it's not just children and teenagers that are at risk. Our list of risk factors go up as we age. Large cohort studies show that older people are a caries active group and that they experience new disease at a rate at least that as great as adolescents. This is due mainly to 2 proven risk factors combined: root exposure and xerostomia. If research tells us that older people are getting decay at the same rate as teenagers, why are we not providing them with fluoride varnish treatments? It takes a minute. It costs less than $2. The Health Policy Institute of the American Dental Association, they released data showing a decrease in childhood caries rates between the 2 time periods shown. We're having great success with reducing decay in children, but sadly, the data shows that an increase in caries for adults is happening. Between 19 and 64, and again 65 and older during that same time period, you can see an increase in caries. So I want you to consider that for a minute. When does insurance stop reimbursing for fluoride for children? It's at about 18 years old. So if you look at these numbers, caries is going down for 6 to 18-year-olds, but the rates are going up at 18. Do you really think that that is a coincidence? I'm not sure it's a coincidence that caries rates go up when professionally applied fluoride ceases. So if research tells us that caries is on the rise in adults, I ask you, why are we not providing them with fluoride varnish treatments? I hope we're all in agreement with the American Dental Association that prevention is possible. I've been following hygienist attitudes toward fluoride varnish for years, and we have had a shift in perceived barriers. The top concerns used to be that patients didn't like the fuzzy feeling and that it was really difficult to apply. We've all lived through that, but those days are long gone. Fluoridose tastes great. It's easy to apply. It doesn't clump on your brush. It doesn't clump on your teeth. You don't have to dry the teeth before you apply it. I can actually apply Fluoridose sitting or standing, and I'm not kidding. I can do it in 45 seconds. If that sounds crazy to you, I want you to go to my website. You're going to find a video of my quick application technique. And when you watch the video, I want you to notice how I hold the mirror and the fluoride in the same hand. That really cuts down on the time that I need for reloading the brush. So I have the brush in one hand, the fluoride and the mirror in the other. And I can seriously do it in less than 45 seconds. The top barrier now is that patients deny treatment when they're told the cost and that insurance isn't guaranteed to help them with it. Another possible barrier is how to apply the fluoride varnish as often as research indicates that it's needed. So I'm going to ask you, are you going to let insurance dictate how you care for your patients? Let's break down these barriers. Evidence-based research has caused the evolution of the standard of care for the use of fluoride varnish. Policy for its use has even been put out by the ADA scientific panel. The research shows and the ADA recommends that we treat patients with known risk factors with professionally applied fluoride varnish. This isn't new and it's not controversial. Many of you might remember in the late 90s when sealants had become the standard of care because research had proven they were effective at preventing occlusal decay in children. We were taught in school how to place them. We placed them in practice and parents paid out of pocket for them. Insurance companies didn't reimburse for sealants for many years, but we still educated parents and we still placed the sealants because it was the right thing to do. We turned in the procedure and we waited for insurance companies to deny it, and they did deny it until they didn't. They finally started paying for it. Insurance companies know more about the procedures we provide than the ADA, the ADHA, dental schools, or anybody else. And why? Because the best metrics are kept by insurance companies. They keep track of every code, every exception, every narrative, everything that we turn in from every dental office. Third-party reimbursement for fluoride varnish is going to happen when the metrics reach a measurable point that insurance companies can no longer ignore. Just like pit and fissure sealants, we have to use the proper codes to change our future. If we want to see third-party reimbursement for adult fluoride varnish, we have to make it happen. We have to make it happen. So how do we do that? If you're using 9910 as the code for fluoride varnish, stop it. You will never get paid on that, and you will not be part of the change in the future that we need. The proper code is D1206. D1206. The description of this is therapeutic application for moderate and high-risk caries patients. When you submit a 1206 to the patient's insurance company, you also need to submit a code for their risk level and a completed CAMBRA form. This shows the insurance company that you're doing risk assessment in your practice and that fluoride varnish is the correct and valid treatment. The code for low risk is D0601, moderate, 0602, and high, D0603. There's no benefit attached to these codes. They are just modifiers. They're just used as a justification. Even if the patient is private pay, though, you still need to record their risk level in their notes. So just to review, D1206 is the varnish, D0602 or D0603 as a modifier, and a completed CAMBRA form is what you need to turn into the insurance company. The ADA and scientific research are definitely on your side. When a patient is shown to be at moderate or high risk, let the evidence dictate your treatment, not the insurance. Now, another challenge that we express is that the patients don't see the value in fluoride treatments. I saw this a lot when I was teaching at the dental school. A dental professional can't introduce fluoride varnish as a preventive treatment at the very end of appointment and tie it only to a fee. The answer is always going to be no. If you want specific dialogue to help you with educating patients, go back and watch the previous webinars, or you can go to the website and read some sample dialogues. I discuss verbiage and give examples of how and when to talk to the patient about prevention during the appointment. But you can't just say, do you want a fluoride varnish? It's $20, because the patient's always going to say no. As I've mentioned before, maybe if you've heard me on the other webinars, you know that I'm a member of numerous closed hygiene chat groups and study groups and Facebook pages. And a topic that comes up quite often is the fee for fluoride varnish. The comments when you ask what do you charge for fluoride varnish, the comments range from no charge to $100. And you can imagine that wide range of fees inspires a lot of discussion. It's some of the best conversations that I've seen online. So I see these answers, and when I start asking questions and digging deeper, something totally expected comes up, totally expected. The lower the fee, the higher the acceptance rate. I have one friend nearby, about 20 miles ago, who works 20 miles away, and she works in 2 offices. They're only a few miles apart from each other. One office charges $45, and she hardly ever gets approval to proceed. Her other office charges $20, and the patient almost always says yes. Now, this is the same dental hygienist giving the same education and getting 2 very different responses. You keep hearing me saying that it takes 1 minute and it costs less than $2, so I broke it down for you in this chart. This is the breakdown of the cost of fluoride varnish application for a hygienist to provide. I used $42 an hour as the average hygiene pay, but even if you use $60 an hour, the cost only goes up 30 cents. As I told you, I can apply it in 45 seconds, so I just did 1 minute to glove, mix, and apply. So 1 minute of hygiene salary plus the cost of the unit dose comes to $1.75 per patient application. So I have to ask you, if it costs less than $2, why are some offices charging $30, $40, $70, even $100? And if they are charging that, what is the acceptance rate? Now, I want to say, if you are one of those offices that's charging $70 and everybody's accepting it, great, keep on doing what you're doing. But the #1 barrier now to applying fluoride varnish is the patient denying treatment because of the fee. If you're charging $40 a day and one person accepts treatment, try charging $20. If you're educating throughout the appointment and using risk factors, I bet that at least 4 or 5 people would agree to $20. You just increase your production by at least double. And I know that as prevention specialists, you would much rather provide protection to 5 people and bring in $100 than one person and bring in $40. I also did the math for an assistant making $25 and a dentist making $100. You can see that even if the dentist applies the varnish, there's still a huge profit. And if you're looking at those numbers and thinking they're crazy, I got those from the Bureau of Labor Statistics, and I actually increased every one of those. So I estimated higher hourly salaries than the Bureau of Labor Statistics did. I did the math for 2 hygienists in an office providing 1 varnish per day, 4 days a work week. Then I subtracted $1.75 for the cost of each application. So you can see here, if 2 hygienists provide 1 fluoride varnish a day, the monthly income is $1,224. If those 2 hygienists decreased the fee and increased the acceptance to 4 patients a day each, the monthly profit is $2,336. And if you look at the totals for 50 weeks of providing 4 varnishes a day with 2 hygienists, you can see there, I only did the math for 4 patients a day each hygienist. But when you start recording the risk factors and present your patients with that, I think you're going to find that at least 6 to 8 of your patients warrant intervention on any given day. I've spoken with numerous hygienists and office managers across the country in varying types of offices, and one thing remains constant. They report when they reduce the fee, it almost always leads to an increase in acceptance by patients. A few weeks ago, I spoke with an office manager in Connecticut whose office is having really great success with their Prevention for Life program. They used to charge $25 for a fluoride varnish application, which I thought was great, but they weren't having very much success with it. The manager is really intuitive and has a great marketing mind, and she started thinking about the difference between $20 and $25, and she explained it this way. If she had a $20 bill in her wallet, she would probably give it up. There's just something mentally more difficult about giving up a 20 and a 5. So they dropped their fees from $25 to $20, and she said that the difference is remarkable. Almost everyone is accepting treatment now, and that's with the same dental hygienist, the same office, the same dentist, everything. So she started calling 20 the golden number. I love that. It's golden number. So if you charge $20, you are recovering all of your costs, plus you're making a profit for the office, plus you're delivering better health to your patients, and they can leave understanding that you did the extra work to keep them healthy. Now, these numbers are only for the varnish application. I didn't even touch on the sale of prescription toothpaste. The ADA has recommendations for 5,000 parts per million fluoride dentifrice, especially for the reversal and prevention of root decay. You could easily provide 5,000 parts per million fluoride to 4 patients a day and add $100 or more to your hygiene production, and you're increasing the patient's health. So remember, increasing the sale of prevention products in the office, it leads to increased profits, but it also leads to healthier patients. Healthier patients mean a healthier practice. Dental professionals tend to get a little uncomfortable. I'm sure some of you are wiggling in your chair right now. We tend to get a little uncomfortable about talking about production and selling products, but let me remind you, the ADA scientific panel put out these guidelines after compiling and reviewing hundreds of research studies. They convened and determined that these were the evidence-based recommendations for preventing tooth decay. Would you rather prevent decay in your spouse or continue to watch as their risk goes unchecked? If you're still concerned, I want you to think about this. If your loved one went to their physician and the doctor didn't advise them to quit smoking and provide them with assistance, what would you think? We're helping our patients reduce risk. Don't consider preventive treatment as taking money from the patient. It's an effective, proven treatment that creates healthy patients and healthy practices. If the patient is at moderate risk, they receive 2 applications per year, and that's easy. It's at their 6-month intervals. The high-risk patient requires at least 4 applications per year. So if they're on a 3-month recall, that's easy. But how do we get the additional applications if they're on a 6-month recall? When the patient's on a 6-month recall, like I said, it's easy. Just do it at their appointment. But this is only a 5 or when the patient's high risk, you have their 6-month recalls, so they can do that's 2 applications a year. And then you can employ a prevention visit or a high-risk reduction visit. Now, this is just a 5 or a 10-minute visit, and it's held, it can be in the consultation room or it can be in any available operatory. The assistant can usually complete the entire visit, too. So the assistant brings the patient to the consultation room, applies the fluoride varnish, answers any questions that the patient might have. Be sure to ask them if they need more toothpaste, more mouth rinse, new brush heads for the power toothbrush, all of those things. And the fee for this visit can be a little bit higher than the fee during a hygiene visit because this is a standalone visit with its own overhead. So feel free to up the cost on that one a little bit. The second example that you see is for a special patient. Misty, a dental hygienist in Houston, first brought this to my attention. She happens to be an OU graduate, but I've never met her. She's from Oklahoma, but I've never met her. She brought this to my attention, and she's having really great success in her practice. Her patient population is older, and they have a lot of root caries and poor oral hygiene. Her dentist is really on board with the prevention and supports her recommendations at every single appointment. They have elderly and nursing home patients that can't perform satisfactory home care, so she has them come in every 6 weeks. They have their regular 3-month recall where the office does a no-charge fluoride varnish every 3 months, but then the patients come in for an in-between visit where the hygienist does a pumice polish and a fluoride varnish application. They charge $45 for this 20-minute visit. So if you count the visits, these patients are getting 8 fluoride varnish applications per year. That's perfectly acceptable. They're just supposed to get at least 4. Many of them are extreme risk, and this is an excellent treatment plan for her patient population. Going a lifetime or the rest of your lifetime without caries is entirely possible. It just requires effort, not only from the patient, but from your entire dental team. Everybody has a part to play in creating a healthy practice and healthy patients. Education without implementation is a waste of time. So I want you to consider these your marching orders. Take a screenshot right now and use this as your to-do list. The patient should be thinking about dentistry as soon as they walk in the door, so hand them a self-assessment form when they check in. This is going to make the patient aware of the risk factors before they even come to your operatory. And remember, this is as much a marketing tool as it is a co-diagnosis tool. We want to get the patient thinking about being partners in oral health. Dental assistants. While the anesthesia is taking effect, you have a captive audience. Use this time to reinforce the bacterial infection education. You can review prevention and restock the patient with their products. Every hygienist I speak with says the same thing. When the dentist backs up the hygienist on fluoride varnish, complaints at the recall visit goes up. So whether the patient is in the restorative chair or the hygiene room, your dentist needs to reinforce the importance of fluoride varnish. Don't waste the opportunity to provide fluoride varnish at the restorative appointment. If a patient requires 4 applications a year, this can be one of those 4 applications. Those applications don't have to be perfectly 3-month spaced intervals to be effective. I hope that you're going to consider all the feedback I've given you about reducing the varnish fee. And office after office have given me the same story. $20 seems to be that golden number. So I want you to come together and decide how you're going to facilitate seeing high-risk patients. And finally, let's take control of our treatment plan back from the insurance companies. You have to turn in the D1206, even if you know 100% that you're not going to be reimbursed. If we want carriers to change, we have to give them the data to do so. Just like the Pitt and Fissure sealants, it will happen, I promise. Whatever your role in the office, the goals are the same: happy, healthy patients and a fulfilled staff and a profitable practice. Prevention truly is a team effort. Dental hygienists, assistants, office staff, and the dentist really do have to be working together to be most effective. Office protocols need to be established and agreed upon. I hope you discovered how many more adults are at risk of developing new decay and just how easy it is to address, especially in the dentist chair. I want to thank Centrix Dental for sponsoring this course. They have been wonderful to work with over the years, and their tagline, "Making Dentistry Easier," is absolute truth. Check out their products, not just their prevention products, but check out their products and see for yourself. I hope you will try the Fluoridose varnish. It is the best varnish I've ever used, and all of my patients have agreed. Looks like we do not, I am so sorry, we don't have time to answer questions, but if you did send me a question, please go to my website and my email is on there, and if you send me a question, I promise I will have it answered before you go to work on Monday. I do see one question here: how do I find the video of you applying the varnish? Go to this website, DonnaBroganRDH.com. And if you go to publications, there is a place that you can you can tap on the video, and they're about halfway through, you'll see the application. How long is the, let's see, I'm trying to get to, how long is the patient supposed to chew the xylitol gum? Excellent question. So a moderate risk, the patient is supposed to chew the xylitol gum 5 minutes 3 times a day, and xylitol needs to be the #1 ingredient. High-risk patient, 5 times a day, 5 minutes each. One more. So when checking out the patient, we bill a D1206 and one of the risk level codes. Yes, that is true, Cindy. Now you're going to turn in the D0602 for moderate or the D0603 for high. You never turn in a D0601 because there is no benefit to doing a fluoride varnish for a patient who is at low risk. And one more. Oh, hello, Sonia. I miss you too. Excellent. All right, well, I want to thank all of you. I'm going to turn you over to take your test now. And again, if I missed your question, please feel free to go to my website, email me, and I promise I will answer your question before you go back to work on Monday. Thank you so much, everyone. Goodbye.